ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया।
Asha madam has joined. Good evening, Dr. Asha.
Good evening. How are you?
Yeah, fine. Welcome, Dr.
We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We shall overcome, we shall overcome, we shall overcome someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday. We walk hand in hand, we walk hand in hand, we walk hand in hand someday. Oh, deep in my heart, I do believe we shall overcome someday.
Harshini ma'am, over to you.
Can we have Asha ma'ams and Shaiju sirs? So good evening, everyone. I would love to introduce Dr. Asha ma'am and Shaiju sir for today's as chairpersons for today's webinar. Asha ma'am is lead consultant at Dr. Aksha Bakshi Fertility Center, Indore. She's second vice president officer, Foxy member representative of Ultrasound Committee of AO4G. She's founder chairperson, MP IAGE and MP ISAR. Past position, she was Secretary General of ISAR 2024 to 2026.
I think that's it. Enough. Thank you.
And can I also have Shaiju sir's so sir's past chairperson and midlife management committee of Foxy, chairperson research committee of KFOG, past joint secretary Kerala Federation of Obstetrician and Gynecologist, past president of Kannur OG Society. Is fertility specialist at Birla Fertility, gynec laparoscopic surgeon at Kannur, Wayanad, and Vadakara. Sir has multiple awards and recognitions, and the recent is SN Joshi Women Empowerment Award. Over to you, ma'am. Over to Asha, ma'am, for introducing.
Yeah.
over to both the chairpersons. Kindly introduce the speakers, ma'am.
Okay. So first of all, I would like to thank the Tamil Nadu Society as well as the Endoscopy Society of India. And it's really a privilege to be at this platform, which is highly scientific and highly academic. And today I'm really honored to introduce Dr. Anju Soni, who is MS Gynae and Obstetric Society, and she's from the Pink City, Jaipur, and she is currently Vice President Foxy, and she has been President IMS, and she has been Vice President Endometriosis Society of India, and she has been governing council member of ICOG, member of CCM, and chairperson HIV and AIDS Committee Foxy. And she has led lots of important positions in various other organizations as well. And she has been editor and Foxy trainer, and lots of accolades to her. And it would be really nice to listen to her about the scientific, latest research and scientific approaches towards endometriosis. So over to you, Anju.
Thank you, Dr. Asha, for your kind introduction. And at the offset, can I share my screen? Can I share my screen?
There is lot of sound in the background.
My background?
No, ma'am. I think
Ramani ma'am,
Ramni, ma'am.
Dr. Ramni, you are, yeah.
Ma'am is in the hospital, I guess.
Are my slides seen? Are my
Pallavi,
slides?
can you help ma'am for her slide?
Okay, are my slides seen?
ma'am,
No,
your
ma'am.
slides are not
We're able-
visible. Rajneesh, please help Dr. Anju to share the slides.
Ramni, ma'am.
Ramani, can you please mute your thing?
Are my slides
Ma'am,
seen?
yeah, it is coming, ma'am. Just wait. You have paused the screen. Jignesh, are you there?
Are my slides seen?
No, not yet, ma'am.
Not yet. What is the
No.
problem happening?
Ma'am, do double click to enter a full screen mode.
Oh, they were full screen from my side.
Ma'am, now you go. Yeah, it is visible, ma'am. Yeah.
Is it fine now?
Yes, ma'am.
Yeah. Am I audible also?
Yes, ma'am.
Yeah. Thank you so much. At the offset, I would like to thank Dr. Pradeep Mitra, Dr. Ramani Devi, and Dr. Asha and Shaijus for giving me such a generous introduction. Dr. Asha herself is known for her academics and her excellence. So thank you, Dr. Asha, for your kind introduction. I am thankful to all the speakers who are here, because we all know that endometriosis is something which we have been fighting the battle over the last so many years. So there are a lot of disturbances. I don't know. I am hearing something behind the. I hope my voice is clear.
I think
yes, ma'am.
Dr. Ramni has to mute herself.
Dr. Ramni, can you mute your? Dr. Ramni,
I have called and informed also, ma'am. 1 minute, ma'am. I will again inform ma'am. I think ma'am has muted.
No, she is not muted.
Now she's muted. Yes.
Thank you so much. Thank you so much. So whenever we talk of modern and future management of endometriosis, our aim is to talk of symptom suppression to targeted patient-centric therapy. And why my slides are not moving? 1 second, my slides are not moving.
It is moving now.
We all know that endometriosis is a chronic estrogen-dependent inflammatory disease, which is characterized by presence of endometrial-like tissue outside the uterus, and with the symptom of dysmenorrhea, dyspareunia, and dysphagia, and it affects about 5 to 10% of reproductive age women globally, frequently causing chronic pain, infertility, and something is wrong. My slides are not. Slides are not. So, when we talk of the past, the diagnosis was often delayed for 7 to 10 years, and the symptom normalized or were underestimated, and the repeat surgeries without understanding the disease were done. And focus was mainly on the visual lesions. But now there is a lot of change when we are talking of clinical phenotyping of disease pattern. We have now advanced uh, mapping devices like transvaginal ultrasound and MRI, and there is a multidisciplinary personalized care, and the treatment is based on the symptom of pain, infertility, and disease severity. And we all know that the future has to future is going to talk of AI driven diagnosis, biomarker based detection, and molecular proliferation and precision and preventive medicine. So basically we are going to talk about the from diagnosis to treatment, we're talking about the precision, predictive, and preventive care. So when we, what we talk about the wound, what she's going through. She's going through chronic pain, dysmenorrhea, painful intercourse. There is fatigue, different symptoms, and then pain severity so many times does not correlate to the lesion size. There is a delayed diagnosis which leads to problem in the reproductive plan, and the woman is unable to conceive, and this may affect the ovarian reserve and the fertility decision. There is a sure need for personalized fertility counseling, and we need to balance between surgery and the IVF decision. Since the women are suffering from years and years, there are many questions which she is suffering. She is suffering from anxiety, frustration. Nobody is, and of course, reduced confidence. Nobody is able to understand what she is going through. And there is invisible suffering affecting relationship also. So we need to be empathetic when we talk, communicate with these patients. And of course, her quality of life is also very poor because that affects not only her work, education, and daily activity. It also leads to sleep disturbances, reduced productivity, and social limitation, and of course, reduced well-being. So we need to restore our quality of life because it is what affects the whole body. It impacts every aspect of woman's life. So there has been changing definition. Earlier, we used to talk about endometriosis considered as ectopic endometrial implants. Diagnosis often confirmed after surgery, and the treatment was focused on removing the visible lesion, and limited understanding of the recurrence and chronic pain mechanism was there. Now we recognize that it is a chronic inflammatory disease. Immune dysfunction contributes to disease progression. The pain pathway and nerve sensation play a major role. So the management now includes not only surgical, it includes medical, surgical, and multidisciplinary care. But when we look into the future, we have to talk about systemic biological approach, integrating genetics and molecular pathways, biomarker division, diagnosis and treatment selection, and precision decision based on individual disease phenotype. And of course, again, the goal is coming back to prediction, prevention, and modification of the disease. So understanding the whole system from surgical removal to personalized care is based on the disease biology per se. Evolution of care in endometriosis evolved in 1990s. The diagnosis often required laparoscopy, focus on excision of visible lesion, limited understanding of recurrence, and pain mechanism was very poorly understood. But now the shift has been from non-invasive diagnosis like expert transvaginal and MRI mapping for deep diseases. Clinical phenotyping guides treatment, and of course, multidisciplinary approach is the whole goal. So in 2030, we envisage for earlier diagnosis without invasive procedure, AI-assisted imaging interpretation, molecular biomarkers for disease proliferating, and predictive and personalized treatment. So again, we are talking of early diagnosis, preventive disease spread, and personalized treatment. When we talk of diagnostic evolution, we need to recognize the symptom, clinical clues early. We need to look for the dysmenorrhea, chronic pelvic pain, dyspareunia, infertility symptom, and understanding the patient's history is very, very critical. The clinical suspicion is on focus history examination, identify high-risk patterns, avoid normalizing severe menstrual pain, that it is a normal dysmenorrhea, and early referral improves outcomes. So diagnosis is again revolves around structured imaging and phenotyping. And then we need to have an expert transvaginal ultrasound, which is first-line advanced imaging tool, which detects endometriomas, deep disease, and maps organs involvement before surgery. MRI mapping is also required in many cases where it defines the extent of deep infiltrative disease, assesses the bowel, bladder, and pelvic involvement, and helps for surgical planning. We need to classify the phenotype of the disease based on the pain, fertility, and anatomy, and enable the personalized treatment decision, again focusing on precise diagnosis and treatment. So there has been a huge evolution in the diagnosis through high resolution machines which are available with us, and also because we have now trained experts who identify the endometrioma and deep infiltrative lesion and provide dynamic pelvic evolution. MRI deep disease mapping is very, very essential because the superior soft tissue characterization is there through MRI analysis. It maps complex deep infiltrated endometriosis and, of course, improves in multidisciplinary planning. And when we look into the future, the AI-assisted interpretation will support the image analysis and reporting, improve the consistency between observers, and future rule in the prediction and automatic diagnosis. So these are the tools which will definitely help us for accurate diagnosis, disease mapping, and AI reporting. So the future diagnostic toolbox contains blood biomarkers, which are non-invasive diagnostic possibility, circulating markers of inflammation and disease activity, which will aim to reduce the diagnostic delay. The molecular signatures of every disease are different. We know that the genomic and epigenetic proliferating, identifying biological subtypes, and guiding the targeted treatment selection. Again, we know that there is a huge role of microbiomes, and role of altered microbial environment is important. Interaction with immunity and inflammation is an emerging area of research which we need to work more. AI prediction is again very, very helpful because it combines the symptom imaging and biology, predicts the disease pattern and outcomes, and also supports personalized decision. So altogether, biomarkers, genomics, microbiome research promises earlier non-invasive diagnosis. What are biomarkers? These are measurable biological signals that indicate disease presence, activity, progression, or response to the treatment. And why do we need them? So that the diagnosis is not delayed for 7 to 10 years, and no simple non-invasive test is there at the moment. Better risk prediction is needed and personalized treatment is needed. And in future, we are wanting to look for genomes, transcriptomics, proteomics, and metabolomics, and AI-driven prediction. So the future depends on the detecting molecular signature, not only the visible lesion. We all know that endometriosis is one disease with multiple phenotypes. Genetics Genetic susceptibility influences disease development, helps understand individual risk pattern, supports personalized approaches, and chronic inflammatory pathway drives the disease progression. Cytokines and immune mediators contribute to symptoms and target for future therapies. So it is a heterogeneous.
Uh, I think Anju Soni ma'am's
Basically,
video
what
is.
is the multiple phenotypes? We all know that immunity is all it's basically altered immune response, which allows disease persistent interaction between immune cells and potential immunomodulatory targets.
Ma'am, your screen is not visible, ma'am. Can you
My
please
screen is not
share?
visible. I
Yeah,
think I'll have to
actually.
share again.
Yeah, ma'am.
Yeah, okay, I'll share again. Is my screen seen now?
Yes, ma'am.
Okay. And we need to understand the pain pathways through nerve sensation. The nerve sensation contribute to chronic pain. Pain severity may not reflect the size of the lesion, and it requires multimodal management. The hormonal response is also variable to the separation, and individual sensitivity influences the treatment outcome and supports the phenotype-based approach again. So different phenotypes drive this personalized endometriotic care. That is what is required. There is a huge changing treatment paradigm. Historically, we used to first do surgery. That was our mentality for excising the repeated excision without leading to ovarian reserve reduction and often leading to ovarian reverse reduction and scar tissue. The modern approach is medical therapy first strategy, early empirical medical treatment based purely on symptoms, delaying surgical intervention to preserve ovarian reserve, shifting from curative, which is surgery rarely, to disease management, that is separation. So the precision treatment model includes pain dominant. Primary goal is to relieve the symptom, address the chronic pelvic pain and sensation, combine hormonal, medical, and pain strategies, and consider multidisciplinary care. When we talk of the fertility, if a patient's need is fertility, we need to focus on reproductive goals, assess the ovarian reserve and the age, balance the surgery with fertility preservation, and individualized IVF decisions are to be taken. When the disease becomes deep infiltrating, we need to assess the ongoing involvement and severity. Preoperative mapping is essential, and multidisciplinary surgical planning is very, very essential. We all know that there is a recurrence risk, so we need to identify the factors which are for predicting the recurrence. Long-term follow-up strategy, maintaining a treatment when appropriate, and monitor symptoms and disease behavior. So it has to be personalized to the disease phenotype and patient's goal. So the current landscape includes hormones which suppress the estrogen-driven disease activity, reduce the pain and the recurrence, and choice depends on the symptom and the goal. Then for the pain, we can do multimodal approach beyond analgesics, address the inflammation and nerve sensation, improve quality of life and function. Surgery is required when we need to excise or ablate in selected patients, require expertise, careful selection, and we need to consider fertility and recurrence risk. Again, that is very important. Fertility is the most important reason when patient comes to us. So individualize reproductive planning, consider ovarian reserve and timing, and again integration with ART when required. So the treatment balances between control, fertility, and quality of life. So when we talk of the first line medical treatment, NSAIDs, analgesics are used primarily for pain relief, but they do not all the lesions. Combined hormonal contraceptives can be given in young girls, suppresses ovulation, reduces menstruation, and can be taken cyclically or continuously to reduce dysmenorrhea and non-menstrual pain. Progesterone like Dynogest are recently available and they are quite effective. They are highly effective at downregulating estrogen receptor and causing deserialization of endometrial tissue. When we talk of the second line medical treatment, we all know that GnRH agonist like leuprolide induces a reversible medical menopause by drastically lowering the estrogen. We can add back therapy, which is mandatory, usually low dose estrogen and progesterone to prevent the bone mineral density loss and menopausal symptoms. GnRH antagonists like elagolix are also very effective. The newer oral molecules that provide the dose-dependent estrogen suppression while avoiding the initial flare-up affect the agonists. Localized estrogen production in the lesion is blocked and often used in combination with progesterone and CSCs for refractory pains. Conservative surgery through laparoscopic excision or ablation of endometrial lesion and adhesions. Endometrioma management by cystectomy is preferred over ablation to prevent the recurrence, but requires meticulous technique to avoid damaging the ovarian reserve. Hysterectomy is considered in cases where uterus is involved, for example, adenomyosis, which I feel is not needed when we can use Mirena or IUCD, and which is quite effective, and in the patient where future fertility is not required. Talking to infertility management, role of surgery of course can clear the pelvic anatomy, clear out the endometriomas to improve the natural conception charts or prepare for IRT. But IVF and ART standard for endometriosis associated infertility has to be focused. The protocol modification is expanded down regulation through long protocols with GnRH agonist prior to IVF cycle is historically utilized but is being critically evaluated based on recent evidences. Beyond hormonal suppression, we can talk of immune dysfunction, which is contributed to the persistent. Future therapies may target immune pathways. Inflammation is the main cause, so chronic inflammatory environment derives disease. Cytokine pathways are emerging targets, and fibrosis changes contribute to the organ dysfunction. Antifibrotic therapies are being explored, and of course, the neural pain through involvement of nerves can contribute to. So, future remains targeting the pain pathways directly. So, the next generation treatment will focus on disease biology beyond hormones. So, the next frontier is: do we operate? The decision for surgery depends on anatomy and goals. Avoid surgery without clear benefit. Consider ART based on age reserve and infertility factors. Individual timing is important. Ovarian reserve is very important because impact of disease in surgery and preserved reproductive potential wherever possible. Individual plan has to be made with shared decision making with patient and priorities, balance pain, fertility, and long-term outcomes. So personalized fertility planning is the central for modern endometriosis care. We all know the research ecosystem is there where AI learning, machine learning integrates clinical imaging and biological data, predict disease pattern and treatment responses. Supports decision making in precision care. Biomarkers are going to play future role by identifying molecular signature of disease activity, enable the earlier diagnosis and patient selection, and guided targeted therapies. So AI, genomics, and collaborative research will shape the future therapies. So we know that genetics have to be understood better through inherent susceptibility, identifying biological pathways involved, support personalized risk assessment, and explore the immune dysfunction mechanism, identify inflammatory target, develop disease-modifying therapies, and validate new drugs, technology, biomarkers, AI model, and translate research. Through this collaborative data-driven research, will advance the precision therapies. There have to be trial landscape through drug targets, move beyond symptom control, explore inflammatory immune fibrotic pathways, develop mechanism based on therapies. Biomarkers validate the diagnostic and preventive biomarkers, identify responders to specific treatment, enable personalized therapy. And AI assess accuracy through diagnostic models, improve imaging, interpretation, and predict outcome. So clinical trials are advancing for targeted AI-enabled precision therapies. From data to decision, we need to talk of symptoms, history, clinical phenotype, patient's reported outcome, and disease characteristics. ultrasound MRI finding, lesion mapping and severity assessment, and AI-supported image analysis, a prediction of disease progression, treatment response assessment, and recurrent risk estimation, and personalized therapy, optimized surgical and medical decision, continuous learning from outcomes. So we need to integrate all the clinical and imaging data to enable personalized care. So the roadmap for the future will be to improve early recognition and structured clinical assessment, advanced imaging-based diagnosis, but look into the development of non-invasive diagnostic tools like biomarkers, validate molecular signature, and use that diagnostic disease, predict disease behavior, forecast treatment response, identify recurrence risk, and modification moves towards disease modification, prevent progression and changing long term. So the roadmap shifts from better diagnosis to disease modification. And the future women leads earlier answers for faster recognition, reduced diagnostic delay, early identification of disease, timely multidisciplinary management. Less suffering, better pain control, focuses on quality of life and daily functioning, addresses the physical and emotional burden. Of course, preserving fertility is very, very important. Early fertility counseling, individualized surgical decision and fertility preservation when appropriate. Personalized treatment again is very important depending on phenotype, biology, and balanced symptom, fertility goals, and long-term consequences. The goal is simple: earlier answer, or less suffering, and personal care. The immunomodulators medication targeting the chronic inflammation and immune system dysfunction that allow the endometrial cell to thrive, anti-angiogenic drugs to cut off the blood supply that feeds the growing endometrial tissue, targeted drug innovations which will be preclinical and clinical advancements like Endo 205 exploring non-hormonal avenues that do not interfere with ovulation. So to conclude, understanding the disease is very important because it is a complex disease, requires an understanding of biology, immunity, and pain pathways, not only improving the lesion. Surgery alone may not address the mechanism. Long-term care requires prevention, recurrence, and symptom control. And woman-centric care is very important because looking at the patient's goal, fertility plan, quality life, we need to take shared decision, which becomes the central part for the care. Endometrial care is beyond women; it is not just a disease. So modern care, early diagnosis with advanced imaging and biomarkers, multidisciplinary patient center, precision science integrating genetics, immunology, AI, moving from empirical treatment to targeted therapy, and prediction of disease behavior, prevention of progression, and improve quality of life. And I'm inviting all of you to this conclave, which is there at Jaipur from 18th to 20th of September. And these are the references I worked from. So thank you very much for patient hearing. Any question, I'm there to answer.
Excellent presentation, Dr. Anju. And you nicely took us from 2026 to 2035. Your roadmap was excellent. And about how to use AI in diagnosis, prediction, and precision of the treatment and prevention of the complications and the futuristic approach. So it was a really very good talk and lots of learning points were there. Thank you very much for the talk.
Thank you, Dr. Asha. Thank you very much.
Shaijas sir, your input too, sir.
Yes. As always, as expected, Anju madam, it was such a wonderful lecture. Always a pleasure to listen to you. Endometriosis is as such a topic which probably has been troubling us as clinicians for a really long time. A lot of updates happening, and I'm sure that the entire team led by Ramani madam as well as Anju madam will show some light and guide us in the right path. A very good lecture. Wonderful to listen to you, Anju madam.
Thank you so much. Thank you so much. Thank you so much.
Thank you Anju, for your very short and crisp presentation on current medical management and what is the futuristic medical management of endometriosis. Okay, thank you.
Thank you, Dr. Amni. Thank you.
Shaijas, you are muted.
You want something from me?
Pallavi, can you share the next speakers? I think it's Ramani ma'am.
Yeah, you can just leave all
Can
those
you-
things. Asha, or if I just leave it, I'll straight away start it with the topic.
I just want to say a couple of lines. I think the amount of effort that Madam has actually taken, Ramani Madam has taken to spread awareness on endometriosis, I think it really deserves a very special mention. I remember when the time she started this journey on talking about endometriosis and taking this topic up so passionately. It was a time when not much was really known about endometriosis. And on the whole, I think the burden of disease across the world, I think, has grown since then. And thankfully, as clinicians, we have been made aware of the changes that have happened related to the diagnosis and management of this disease, primarily because of the efforts led by people like Ramani Madam. So, much more than what is written on the slide, I think what deserves a special mention, I think, is the effort that Madam has taken to spread awareness about this disease. So, on that note, over to you, Madam.
Thank you, Sanjay.
Ramani, just a little note. Ramani and endometriosis, they go hand in hand. We recognize Ramani as endometriosis person.
Okay.
Thank you,
Thank you.
Thank you,
So let me
Ramani.
share my
Surely, Dr. Ramani, I also echo the same sentiment.
Okay. Can you see my slides?
Yes, ma'am, we can.
Okay. So, ma'am, I really appreciate Anju Soni for having taken an interest in the biomarkers, which is my favorite one in early non-invasive diagnosis of endometriosis. So, now the topic what I have chosen is why medical management is gaining preference in endometriosis. So, I think this I have told a number of times. This is a beautiful 1,000-pillar courtyard in Srirangam temple. This is our beautiful river Kaveri, and you can see the rock fort. And this on the other side is the Italian church. You can see this picture. So endometriosis, by definition, all those things I'm going to skip because of lack of time. And the prevalence, it is highly prevalent. It is increasing in incidence. In the infertile population, it is 25 to 40%, and 75% of the women with chronic pelvic pain, you have to think about endometriosis. And this is very important. Any young girl presenting with features of progressive dysmenorrhea, you have to think about endometriosis. And it is this stage, even before there is positive imaging findings, this biomarkers can help us to pick up endometriosis, which can be treated earlier. So in the recent estimates, about 246 million women suffer from endometriosis globally as per the WHO report. And according to the Endometriosis Society India report, 50 million women suffer from endometriosis in India alone. And these are all the various phenotypes which everybody is aware. And the American Society for Reproductive Medicine says endometriosis should be viewed as a chronic inflammatory disease, and that requires lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedures. So the treatment aims in elevating the pain and promoting fertility, reduce recurrence, and improve the quality of life. Earlier, when endometriosis, when we were as postgraduate, when we were reading, we used to think that it is an hormone-dependent condition where there is hyperestrogenism with the progesterone resistance. But now we know it is the chronic inflammation and the fibrosis that causes much more pain, and the medical management is going to be the pillar of treatment of endometriosis. So this, I think I can skip one in that. Now coming to the diagnosis of endometriosis, just the history can tell you clinical examination, imaging, biomarkers. If imaging is negative and if the history and clinical examination are positive, trial of the treatment. And there is no place for laparoscopy for diagnosis in this era. And as Madam has been telling about Ds, I am very fond of telling a 7 Ds plus 1 D, that is the depression. That is dysmenorrhea, dyspareunia, dysuria, dysphagia, dysfunctional uterine bleeding, diffuse abdominal pain, and difficulty in conception. Everything will lead to depression and fatigability. So this is the clinical features, the 7 Ds, which have been given again. And the management can be either pharmacological, physiotherapy, psychological therapy, surgery, pain education, support networks, and the lifestyle modification. So we have to understand that surgery is not the only one, and we have to basically depend upon the pharmacological and supportive as psychological, cognitive behavior therapy, etc. Then physiotherapy and supportive networks are very, very essential. And of course, the lifestyle modification. Again, this is a disease of different ethnicities and from adolescent to postmenopause. I would like to say it roots in utero and ends in 2. So at various stages producing various types, like it starts genetically or in utero, and then early onset adolescent endometriosis you can see in the first decade, second decade, late onset adolescent endometriosis, and third decade reproductive age group, and the fourth decade perimenopausal. And even with the perimenopause, we cannot say that the disease ends with that, because we now see a lot of patients with during the postmenopause. And not only that, it leads to endometriosis, it progresses, but it causes other comorbid conditions, because we know it is associated with conditions like early onset arthrogenesis, cardiovascular disease, and cerebrovascular disease, plus the autoimmune diseases are all increased comorbid conditions in patients with endometriosis. So the diagnostic delay, we say it delays from 4 years up to 9 years. And here I have put in a diagram where based upon the phenotype, you can, the diagnostic delay. See, abdominal wall endometriosis, that is scar endometriosis is picked up very early, but whereas deep infiltrative endometriosis can be diagnosed only between 7 to 10 years, and adenomyosis, of course, late. But now we see adenomyosis even in young girls, say 15 or 16, coming with progressive dysmenorrhea. And again, based upon the symptoms of pelvic pain, you get varying years to for the diagnose the disease, which may range from 1 year up to even 12 years. So then biomarkers, once again, biomarker has got a clear impact in reducing the diagnostic time. It can help in the follow-up of the treatment, and it could be clinically useful and monitoring the progress of the disease. It can replace invasive diagnostic methods, and the criteria to have biomarkers is they should have a sensitivity of 94% and the specificity of 79%. And I have been working on biomarkers, especially the microRNAs, and we find that some of the microRNAs are dysregulated, and they are signature microRNAs for each disease. For example, a group of patients with PCOS has a biomarker miRNA which are dysregulated, and it may not be the same with the endometriosis. But in endometriosis, we have picked up 5 biomarkers which are clinically very useful. So imaging, of course, only in late stages, but now with the advent of PET scan and MRI of high resolution, we are able to now pick up even a 0.5 centimeter size endometrioma. And in ultrasonogram, a properly done ultrasonogram can pick up very early endometriosis, and IDEA group is the one which says that it can be picked up much earlier with the indirect evidence of ultrasonogram, like the sliding sign and immobility of the ovaries and the rectovaginal endometriosis can also be picked up with high resolution ultrasound machines with extreme good training. So now the empirical treatment according to the various learned societies are only medical management. This is X-ray, ASR, and ACOG, British Society of Endometriosis, then FOXY, and this is the this one, French one, and the British Fertility Society, and NICE. All of them are for medical management. Early and accurate diagnosis is the key for better treatment. So which treatment is ideal? Now the debate comes, whether you have to go for medical management or whether you need to go for the surgical management. So the traditional surgical era in which we were trained, surgery was found to be the historically considered as the gold standard, and that too laparoscopy for diagnosis. And in laparoscopy, we use it for diagnosis, excision, ablation, and endometrioma removal. And see and treat was the philosophy in those days. Why surgery dominated? Because we did not have good medical option. And then we needed the diagnosis for diagnostic confirmation. Then only we used to start the patient on medical management. But nowadays, based on the symptoms alone, it is enough. We can start the patient on medical management. Why medical therapy is now again rising? It is because endometriosis is not a one-time disease. It is a chronic recurrent disease. And all of us know that even after surgery that has been done extremely well, at the end of 2 years, there will be 20% recurrent. And at the end of 5 years, it can be 40 to 50% recurrent. So that means by doing surgery, we are removing only the diseased part, what is to be removed. But the basic etiopathogenesis, like the genetic or epigenetic changes or the retrograde spill, whatever it is that we are not touching with the surgery. So medical therapy also avoids the risk of operative risk. Newer hormonal agents are practical and they can be used for a very long time. Non-hormonal treatment is coming up in a big way, and treatment should be more precise, target-oriented, and AA-based. That has been clearly mentioned by Dr. Anju. Why surgical decision is not always preferred? Because we know it is a heterogeneous disease. Pain lesion mismatch. See, like for example, a patient with a very early endometriosis will have an intolerable pain. But at the same time, a patient with a large endometrial mass can be asymptomatic and it may be an incidental finding when they do the surgery. So then regarding the fertility consideration, we know that fertility can be hampered by doing repeated surgical excision where it will reduce the AMH level. And the recurrence risk about which I have mentioned, ovarian reserve is compromised and there may be multi-organ involvement. Why not to consider surgery? Endometriosis as a chronic recurrent disease. Surgery treats the lesion but not the disease biology. Multiple surgeries are common and recurrence remains high. Hence, we need to think twice before taking any decision. Again, there is a diagnostic paradigm shift, what Dr. Hanjigat said, from old model of symptoms to diagnostic laparoscopy, and the current model is only symptoms plus imaging, clinical suspicion. Maybe we can add biomarkers which can help us to start the medical management empirically. So then ASRM ACOG guideline principles are, it should be individualized decision making. Surgery is not the first line for all patients. Consider fertility goals, balance benefit versus ovarian reserve, and prefer expert centers for surgery or DAE. See, we don't say that surgery should not be done for any patient, but there are definite indications for surgery in a patient with endometriosis. So, Hippocrates, make a habit of 2 things, to help or at least to do no harm. So, why not to operate? Minimal disease with controlled pain, there is definitely no need for surgery. Asymptomatic, don't need. And when fertility is decided also, preferably you go in for ovulation detection with IUI or ART. And when there is already a poor ovarian reserve, do not attempt surgery. And when you have IVF plant, immediately also no surgery. And lack of surgical expertise, as in the cases of DIE. Because not every common gynecologist or an average gynecologist is capable of handling a deep infiltrative endometriosis, which may need rectal shaving, discoid excision, or sometimes resection and anastomosis. So that has to be done only in a center of excellence. So now the goals of the medical management are suppress ovulation, reduce inflammation, improve quality of life, delay recurrence, and preserve the fertility. These are the main things. So now explore effective pain relief and non-hormonal management option. And there are a lot of newer drug targets for endometriosis pain. So the factors influencing the choice of the therapy depends upon the age, fertility need, symptoms, severity, pre-treatment, prior treatment, what the patient has had, cost involved, side effects, and what the evidence says. So why medical treatment should be preferred? One is you can avoid the surgical risk, minimize ovarian reserve damage. Managing a chronic disease is always medical management, preventing repeated operation, targeting pain at the source, temporary disease suppression. So these are all the indications. So the timeline for medical management, earlier in 60s, we started using COCs. And then in 70s, we started using oral progestins, and 1990s, it was agonists which were used for quite some time. And later, in 2000, we were using GnRH. 2000, we were using LNG IUD or selective estrogen receptor modulators and sperm. Again, now we have this GnRH antagonists which have come into vogue in 2020s. And again, there may be management with non-hormonal, like cannabinoids can be used for extreme pain and palmitoyl ethanolamine, melatonin. And of course, we have the emerging therapies like the gene therapy and other personalized medicine, immunomodulatory agents can also be used. And there are, of course, biomarkers which are dysregulated can be corrected with specific personalized treatment. So the newer drug therapies are relugolix, elagolix, linsagolix, of which we are commonly using elagolix and relugolix. Though linsagolix and relugolix are used in the European country, we have progestin antagonists, then aromatase inhibitors and immune modulators, anti-angiogenic drugs as non-hormonal, and selective estrogen receptor modulators and sperm. And of course, statins, we think that it has to be used only for hyperlipidemia, but we know that there is a common link between these two diseases where this statins HMG-CoA reductase can reduce the inflammation, and estrogen receptor beta ligand. This is one of the very few drugs which will not inhibit the ovulation, and hence it can be used for pain relief in patients needing fertility. So the drugs, these are all some of the newer drugs, melatonin, palmitoyl ethanolamine, and cannabinoid can be used for a very long time. It has to cause endometriotic cell apoptosis, anti-inflammatory effect, and then there is increased production of ROS and epithelial to mesenchymal transition. This can be inhibited by certain drugs like ROS. For ROS, they say antioxidants can be used. For epithelial mesenchymal transition, simple aspirin is of use, and angiogenesis can be inhibited by gabapentin or so. Then the production of estradiol, which is the basic cause. So you should always remember that E2 to E1 ratio is very essential, and estradiol 2 is converted into estrone by 17-beta-hydroxysteroid dehydrogenase, which is inherently deficient in endometriosis, and that is the basic cause where there is piling up of E2. Then endometriotic cell proliferation can be angiogenic factors, neurogenic factors, neuroinflammation can also the causes, and we have specific drugs which can hit this pathway. Elagolix trial data shows that the Celaricium 1 and 2 trials are there, which can be reduce dysmenorrhea, and specifically it can reduce non-menstrual pelvic pain. In general, we use Dynages as a first line, but we have to understand that Dynages does not reduce the pain in 33% of the patient, and these are the group of patients who need elagolix or the antagonist, and it can reduce both dysmenorrhea, reduce non-menstrual pain, improve the functionality, but the limitation is we cannot use elagolix for a longer time because of vasomotor changes, VMD reduction, and the cost issue. But one thing is elagolix is dose adjustable. It can be given at 200 milligram BD in severe cases like dyspareunia, and in milder cases, it can be given as elagolix 150 milligram OD. When you choose the higher drug, it can be continued only for 6 months, but we need to have an add back. But the low dose 150 milligram can be continued even up to 2 years. The studies are there up to 2 years. Then coming to the relugolix combination, we have the SPIRIT trial. Originally, relugolix was used for treatment of fibroids, but now we know the basic etiology is hyperestrogenism, and the SPIRIT trial says there is significant reduction in pain, improved dysmenorrhea, improved non-menstrual pain, better quality of life scores, oral one-stage option with an add-back therapy, and there is dramatic improvement in the pain over a period of 24 weeks. So now let us see what is the pathophysiology of the pain. The endometriotic lesions, by a process of chronic inflammation, they start releasing the cytokines, interleukin 1b, tumor necrosis alpha, and the prostaglandin. They will promote neuroangiogenesis. Hence, there will be peripheral nerve sensitization, which later on leads to central sensitization. And beyond that inflammation, we have the myofascial pain, which will lead to chronic pelvic pain. So this is a very important slide where the central sensitization is not cured by surgery. So what happens is peripheral sensitization, they have the nociceptive pathway, repetitive pathway is there. This will expand the nociceptive pathway, and it will cause spinal hyperalgesia, chronic pelvic pain, and pelvic floor dysfunction. So which will later on expand into formation of nociceptive pain, and there is this will produce the signals that are coming, reducing the signal, inhibiting signals. And again, we have to understand that there is alteration of the brain morphology in patients with lower pain threshold also. Important 5 factors are expansion of this nociceptive field leading to nociplastic pain, brain morphology is changed, reduced pain threshold, decreased inhibition of the incoming signal, and hypersensitivity to the incoming signal. That is hyperalgesia. All these things are not handled by surgery. So then overview of the newer projects are inflammatory mediators has to be suppressed, neurogenic pathways, angiogenic and immune pathways, and ion channels. So this targeted pain therapy is the need of the hour. So now we have the emerging therapies in medical management. One is our novel pharmacological approaches. These are the routine things what we use, and aromatase inhibitors can be used as a second line agent. And now advances in the surgical technique is also there, that is from minimal invasive laparoscopy to robotic surgery, which has got a higher precision. But then according to the gene and molecular therapies, we know that epigenetics and genetic changes are there, and by gene editing using CRISPR technique, we can actually alter the gene editing can be done, which can revert the endometriosis. Other innovations are stem cell therapies, immunotherapy, non-pharmacological therapies like what I have explained earlier, that is cognitive behavioral therapy, supportive therapy, then myofascial relaxation and other interventions. So these are some of the newer drugs which are very, very specific and precision drugs, I should say. Estrogen receptor ligand, and then tumor necrosis P470, endostatins, dopamine agonist, neuroangiogenesis that inhibits neuroangiogenesis, rapamycin is an antifungal one, doxycycline, PPARS, and all these tumor necrosis alpha inhibitors, COX2 inhibitors, and serotonin modulators, and gabapentin is a drug which can inhibit the central sensitization. Of course, we now have the palmitoyl ethanolamide combination that is available. So the interventional pain management is, you have to understand what is the type of neuropathic pain, whether it is peripheral neuropathic pain or visceral pain. Peripheral pain, you can have buttocks pain, inguinal pain, leg pain, genital pain, abdominal wall pain, and myofascial. So all these particular nerves can be blocked. So that is one thing at the right intervention. But we have to again remember that interventional pain management will not be permitted, will not be permanent, but we need to repeat it every 1 year or 2 years or so. Then the visceral pain is pelvic pain, superior gastric, hypogastric plexus block, and genital and rectal pain with the ganglion. All these ganglion blocks can be attempted. So now for anything and everything, we know that alteration of the gut microbiome is the reason. And here again, for the endometriosis, there is altered gut microbiome. Because we know that there is inflammatory bowels and Crohn's disease are more common in association with the endometriosis. So protective gut bacteria are low in endometriosis, and hence initially when endometriosis is presenting with features of pain, we always tend to mistake it for pelvic inflammatory disease, and all of us have the habit of putting the patient on doxycycline and metronidazole, and the same thing will reduce the pain as well as reduce the size of the lesion. And of course, use of probiotics to boost the gut protective microbiome is essential. So the microbacterial treatment, that is essential. It can be probiotics or prebiotics can be supplemented, and we now have the phage therapy and fecal microbiome transplant, FMT, can also be, like from the healthy person, the microbiome of the healthy person can be transplanted into the patient with endometriosis, and engineered bacterial cells can be infused, or live biotherapeutic products like the pre and the probiotics can be given, so that they can be other specific targeted drug treatment. So then finally coming to the research cells, that is stem cells, we know that we think that the endometrial stem cells shed during menstruation, and that is the cause for the ectopic lesion. Again, the bone marrow derived mesenchymal cells can circulate and they cause the disease in the ectopic cell. The stem cell theory suggests that dysregulated stem cells from the endometrium and other sources, they only develop into the endometriosis. And the induced pluripotental stem cells can again the same thing. it can be used for regeneration. Sorry. So the therapeutic option of the stem cell is it can be used for tissue repair. It can have anti-inflammatory effect because they can modulate the immune response by reducing the pro-inflammatory cytokines and increasing the anti-inflammatory, that is interleukin-10. Targeting mechanism treatment aids to inhibit stem cell migration or utilize the regenerative properties for the cure, true cure, and just not symptom management. Challenges are there are certain clinical challenges with the long-term efficacy and tumor risk and storage. Future focus may be in developing targeted therapies to correct the disease mechanism, improving delivery and using stem cell as a. Then comes the gene therapy. In the past, adenovirus gene therapy has been used, but at present, microRNAs that are aberrantly expressed in endometriosis, it can be the same thing can be used for treatment. For example, microRNA LET7B is grossly downregulated and it can be supplemented so that we can treat endometriosis. Similarly, Aridia 1A mutation is found in 94% of the patients with endometriosis, and that can be corrected with certain EZH2 inhibitor treatment. Then, indications for surgery, when you suspect malignancy, large asymptomatic endometrioma, bowel obstruction, hydrouretus, failed medical therapy, and fertility indication in certain selected cases only, because all patients, they don't need surgery. So what are the problems with the surgery is surgery can lead to additions, ovarian damage, bowel injury, ureteric injury, bladder injury, and persistence of chronic postoperative pelvic pain. So the recurrence after surgery, I have already mentioned, this was a study by Sanvi et al. And the factors causing recurrence is, one is incomplete surgery. Earlier, we used to think that is the incomplete surgery is the cause, but now we understand even after complete surgery, the patient can have recurrent, and the hormonal imbalance, which is inherent, genetic factors, advanced endometriosis, and age and menstrual, older age and early menarche are the cause, and of course, lifestyle, poor lifestyle changes. So, indications for laparoscopy in adolescent. See, adolescent girls, generally, we tend to treat them only medical management, but this is a laparoscopic view of an 18-year-old college student where she has no relief with the dynages, and hence, at one stage, I had to go in for a surgery. She had a bilateral endometrioma with deep infiltrative endometriosis. And again, that is definite indication, and endometriosis associated with Mullerian anomalies. We need to do surgery because correction of the Mullerian anomaly can reduce the progress of the lesion. And other emergent situation is rupture endometrioma, and in recurrent endometrioma, when you have severe pain, larger size, and suspicions of malignancy, we need to go. Preoperative decision factors are age, fertility desire, pain, severity, previous surgery, AMH, imaging finding, and the surgeon's expertise and a teamwork is the most important. Decision pathway is whether you want to tackle the pain or the infertility or the mass or DIE or recurrent disease and organ dysfunction like hydronephrosis. Pain dominant pathways for indications for surgery are pain not responding to medical treatment, certain conditions where planning fertility, and endometrioma larger size, DIE not responding to medical management, and bowel and bladder involvement, any organ involvement with causing narrowing, for example, hydronephrosis or obstruction to the bowel, I think they need only surgery. So patient preference after counseling and suspicion of malignancy were important pathway. When to avoid surgery in AMH? When the patient is elderly, asymptomatic endometrioma, small lesion, low AMH, bilateral previous ovarian surgery, and IVF are planned. The same thing is given in the HDEC guideline. So then this is a picture to show that unilateral and bilateral laparoscopic surgery for endometriosis and the levels of AMH. So definitely the level of AMH comes down after bilateral laparoscopy for endometrioma, and they say that there is a slight increase after few months. But I think any surgery, unilateral or bilateral, there is definite reduction in the AMH level. So this is again another picture to show preoperative prior to OMA resection, 4 months and 8 months. And again, this is for DIE and this is for OMA plus DIE. So always in patient with when you are doing surgery, we have to counsel, especially if the patient needs fertility, that there is definite reduction in the ovarian reserve. Then ESHRE, avoid repetitive surgery except when there is severe pain not responding to medical management. Consider ART instead of surgery. fertility preservation is one thing we need to advise the young girls for whom we are planning surgery, and rarely surgery may help in cases of failed ART. Then that means you do a ART, repeated failure, but the surgery, if you are able to correct it, it can improve the outcome through repeat ART or spontaneous. Definitive surgery in patients who have completed family if there is an organ compromise. So imaging-based surgical management is for endometrioma, rectovaginal nodule, uterosacral disease, bowel and ureteric compassion. The surgical options are always go for a therapeutic laparoscopy. Laparoscopy versus robotic surgery has to be considered because now we have the facility. Excision versus ablation, which can reduce, always excision is preferred, and cyst aspiration is not preferred, but only cystectomy is ideally needed. But we need to understand cystectomy reduces AMH, and certain situations we can go for cyst aspiration, and then sclerotherapy is also coming up. And in DIE, the role of ICG can help us to reduce the ureteric injury, and nerve sparing injury is the now the mode of surgical management. So the infertility dominant pathway, if there is stage 1 and 2 laparoscopic treatment, improves the outcome. Endometrioma, avoid routine surgery prior to IVF. Endometrioma with pain not responding, maybe you can go in for surgery. And if it is affecting the access to the oocyte, go ahead with surgery. Hydrosalpinx has to be removed or clipped prior to ART. DIE surgery is only in limited patients you do it, especially when the patient has got narrowing of the lumen. And again, it improves the spontaneous pregnancy rates following surgery in 50%. Low AMH, reduce surgery, recurrent, better avoid. So excision versus ablation, I have mentioned that it can be offered as a treatment for stage 1 and 2 that improves the outcome of the pregnancy. In early endometriosis, again, you have mild addition. Clinicians do not recommend to perform surgery prior to ART to improve the birth rate. But if the patients are asymptomatic, and then definitely there is a role for asymptomatic patients do not go in for surgery. But if the patients are symptomatic, probably it is the place where you need to go for surgery. And this is a patient with a septal dissection, septate uterus, where septal dissection along with the endometrioma excision had yielded a healthy pregnancy for her soon. So this is again the painful, not responding to treatment, suspicious feature, rapid growth, and infertility with access is obscured. Cystectomy is avoided, and better to avoid drainage, use cystectomy, but caution the patient with AMH. Then use the traction and counter traction and consider hemostasis perfectly. Because after doing surgery in infertile patient, the most important thing is we need to put the endometriosis fertility index, which will help us to guide the surgeon as well as the patient. So if the endometriosis fertility index scoring is beyond 7, then the spontaneous conception is quite good. And if it is less than 3, we need to go only for IVF. In between, probably depending upon the age, male factor and the tubal factor, we can try a short 1 or 2 cycles of IUI. So then deep infiltrative, shaving, discoid excision, and segmental bowel retention. This is the patient with the deep infiltrative endometriosis, where you can see in the hysteroscope this posterior endometrioma. And again, this patient had got a DIE, which was like I had not gone in for a excision, just an adesolysis was done, following which the patient was subjected for ART. So this is the endometriosis fertility index about which I am talking. 7 to 8, good prognosis. Beyond 0 to 3, no patient has to be straightaway taken for ART. And 4, 5, and 6, maybe we can try with a few cycles of IUI. So these are all some of the guidelines which are given in the ASHRAE guideline. And then finally, medical or surgery for postmenopausal endometriosis. These women, they need a surgery with a long-term suppression, and definitely surgery has to be done based upon the patient's requirement. For example, patient with who is around 40 to 45 with a unilateral endometrioma, not responding, probably the unilateral salpingo-oophorectomy can get the patient good relief, and currently there is no place for Luna or presacral neurectomy, and hysterectomy with BSO can be done for patients who are beyond 45 years completed the family, but always remember the post-operative suppression therapy with GnRH antagonists or aromatase inhibitors or progestins are a must to prevent the recurrence. So even after doing a complete surgery, we cannot tell the patient you won't have recurrence. So this is a narrative story where this dysmenorrhea, OCP, NSAID and analogs can be used. Chronic pelvic pain needs a multimodal management. Central sensitization, we need to go medical surgical therapies as well as this gabapentin. Dyspareunia management, invariably it will respond to GnRH antagonists at a higher dose, or pelvic floor therapy or neuromuscular approaches can be done. Then multidisciplinary team is the most essential one, and long-term integrated treatment is essential. So medical and surgical management of endometriosis, individualize the treatment, immediate pain improvement will be there after surgery, durability of pain relief, it's better after complete excision and then post-operative suppression, and pain recurrence depends upon the younger age, higher there will be recurrence as well as the subtype phenotype of the patient. And then the hormonal suppression is very, very essential following surgery. So the lifestyle modification is the utmost one. And a minimum period of 2 hours per week, you have to go in for exercise. Trans red meat has to be reduced. Omega-3 fatty acid should be used. And of course, the holistic way of approaching is physical supportive therapies like diet changes, physical therapy, stress-reducing activities, acupuncture, yoga, mindfulness, and calm the nervous system and reduce the stress by using breathing exercise, meditation, and guided relaxation. So then, so the future directions are AI-based, once again, biomarker-based, non-invasive imaging, personalized treatment, and it should be patient-centered. What is the requirement of the patient? We have to understand. Non-hormonal should be preferred, targeted pain pathway, combination therapy in future and surgery should be carefully chosen, and need for clinical trials are warranted. To conclude, it is a chronic inflammatory disease, not merely a surgical condition. Repeated surgery should not be done, and central sensitization and persistent pain is always there. And modern medical therapies aims to suppress the disease activity, reduce inflammation and neuroangiogenesis, and control pain effectively, preserve fertility and ovarian function, and improve long-term quality of life. And personalized long-term medical management is the mode of approach. Okay, then surgery plays a selective role when you are not sure of diagnostic uncertainty. Organ distortion and obstruction is most essential. Infertility, certain indications, and refractive pain. So the take-home message is the paradigm shift in endometriosis care, repeated excision to sustained disease suppression. From excision, we are going for disease suppression, operating on lesions to managing a lifelong condition. So to say it roots in utero, starts at 20, progresses at 30, problematic at 40, supposed to end at 50, malignant risk at 60, and needs follow-ups forever. So thank you for the opportunity. And this is the team from Satyabama University where I work for this miRNA studies. Thank you so much.
Excellent talk, Dr. Ramani. Very detailed, and it's very nice that you really stressed a lot of importance on medical therapies, because there are only particular indications where surgery is done. Gone are the days where you used to insert a laparoscope for every suspected endometriosis case. And it is very nice that you enumerated and you talked about all the medications available. It's not just few medications. Now we have got a variety of medications, and lots of medications are available, and I'm sure in future more will be available, so that we can really be very precise in our treatment and try to conserve the ovarian reserve as much as possible and conserve the fertility as much as possible. And we have to be very empathetic, and we have to understand that the quality of life in these patients is really important, and you very beautifully demonstrated how to control the pain also in these patients. So it is an excellent talk. And
thank you, Asha. Thank you. Thank you so much. Harshini, the chat box.
Before going to the next speaker, there's a question from Dr. Neena Kulkarni ma'am from Mumbai. For a patient with diagnosed DIE on MRA who's asymptomatic and has finished her fertility, will medical management like GnRH antagonist for 4 to 5 years is useful?
I think
Kindly
after
give your
listening
opinion.
to my lecture, unless there is an occlusion of asymptomatic beta don't follow up only. Then if the patient is not having any occlusion of the GI tract, I think medical management still continues, because we need to understand by doing a surgical radical surgery, there are complications like fistula formation and so many other infection, etc. So I think in asymptomatic, even if you diagnose DIE with MRI, try only with medical management, and especially if she is not bothered about her fertility. In a perimenopausal woman, maybe we can use this drug for quite 4 to 5 years. The exception is when there is a doubt regarding the nature, whether it is benign or malignant, or when there is no when there is obstruction to the gut, we need to go in for surgery. Otherwise, no need. For example, there may be ureteric endometriosis. The thing is, if the patient has got associated hydronephrosis, definitely surgery is their indication. Because hydronephrosis secondary to periuretic obstruction, it will go in for a silent renal damage. So whenever these tubular structures are obstructed by the disease, I think it is always safe to go in for a surgical correction. They may not respond to medical management, or rather the quality of life will be reduced.
Thank you so much, ma'am. I think it would have helped her. Next, we'll go to the next speaker. Ma'am, can you introduce Dr. Tendril?
Yeah. It's indeed a privilege to introduce Dr. Tendril, who is a consultant obstetrician and fertility specialty at Arun Hospital, Krishnagiri. And she has done ICOG certification course in ART, and she's consultant at Sri Vidya Hospital, Krishnagiri, as well as at Gunsekharan Hospital, Chennai. And she's MRCOG DNB and has done MS MS in OBGYN. So welcome, Dr. Tendril, and let's listen to your talk. On,
once again, I'm happy to say Tendril is my student. And she had won the first prize in ICOG examination in reproductive medicine.
Very good. Excellent. Excellent. So it would be nice to listen to your talk on cardiovascular disease in endometriosis. Yes, this is another aspect. So something really new.
Thank you, ma'am. Are you able to see my screen?
Yes, yes, we are. You can put it on the full screen slide.
Yes, ma'am. Yeah. So good afternoon, everyone. My topic for today is endometriosis as a cardiovascular risk factor. So endometriosis, as we all know, it affects around 5 to 10% of reproductive age women. So worldwide, around 190 million women are affected. And when we take only infertile women, up to 50% of women are affected with endometriosis, and it has significant impact on quality of life and productivity. So we as obstetricians and gynecologists, we focus mainly on the fertility part and the pain part, and we offer treatments like medical management and surgery. Most of the time, the long-term cardiovascular health is often overlooked. So cardiovascular disease per se in women is the leading cause of death worldwide. And many female-specific risk factors are now being recognized, like hypertensive disorders of pregnancy, gestational diabetes mellitus, premature ovarian insufficiency, PCOS, etc. And with this, endometriosis should also join the list. So why cardiovascular risk is increased in endometriosis? Because both have similar biological pathways, which is chronic inflammation, oxidative stress, which leads to endothelial dysfunction and increased pro-inflammatory cytokines, macrophage activation, which in turn leads to angiogenesis in endometriosis and atherosclerosis in cardiovascular disease. So this is just a pictorial diagram where it shows that this chronic inflammation, increased proangiogenic signals, and vascular impairment, along with immune dysfunction in endometriosis, in turn increases cardiovascular risk. Especially extrapelvic endometriosis, like endometriosis above the diaphragm, pleura, pericardium, can in turn increase the risk of cardiovascular disease. So the pathology of endometriosis per se, it involves 3 distinct pathways, which is increase in pro-inflammatory cytokines, which is increase in neutrophils and macrophages in the peritoneal fluid or in the ectopic endometrium, increase in pro-angiogenic signals, where we can see there is increased VEGF expression, and there is altered endocrine signals, that is increase in estrogen receptors and increased estrogen production in the ectopic endometrium as well. These 3 pathways interplay and helps in progression of endometriosis. So this progression, that is the chronic inflammation, in turn leads to cardiovascular disease. The chronic inflammation of endometriosis, like interleukin-6, tumor necrosis alpha, and interleukin-1b, causes persistent inflammation, which leads to endothelial injury and atherosclerosis. The reactive oxygen species, like increase in reactive oxygen species in endometriosis, causes nuclear factor kappa B activation, which leads to endothelial dysfunction and arterial stiffness, which in turn can lead to cardiovascular disease. So, in ectopic endometrial tissue, what happens is that there is recruitment of leukocytes, macrophages, tumor necrosis factor, excess pro-inflammatory cytokines, which causes chronic inflammation, oxidative stress. There is estrogen dysregulation, and this also has effects on lipid metabolism and endothelial function. So this causes increased atherosclerosis, hypertension, coronary artery disease, ischemic heart disease, etc. This is endothelial dysfunction. What happens in women with endometriosis? It is noted that there is reduced reactive hyperemia index and increased augmentation index. This in turn leads to decreased nitric oxide availability in the blood vessels, which causes reduced vasodilation, or it causes vasoconstriction. So this leads to early vascular aging and atherosclerosis. Also, women with endometriosis and women with cardiovascular disease, these two have shared genetic loci. And this is located in 9th chromosome and 7th chromosome. The important loci are CD, K9, 2B, AS1 and 7q22. These 2 genes regulate cell proliferation, angiogenesis, inflammation and vascular remodeling. So this in turn leads to shared genetic susceptibility, which causes more endometriosis as well as cardiovascular risk in women. So European Society of Cardiology proposes that since there is increased risk of cardiac outcomes in women with endometriosis, women should be screened for female-specific risk factors for cardiovascular risk assessment. This is another meta-analysis published in 2023. It states that women with endometriosis are at higher risk of getting ischemic heart disease and cerebrovascular disease. So further studies are required to evaluate the risk of cardiovascular mortality in women with endometriosis. And this is European Menopause and Andropause Society, which is published in July 2026, and it says that there is significantly increased risk of cardiovascular disease in women with endometriosis, especially ischemic heart disease and cerebrovascular disease. And whether the disease per se or the treatment for endometriosis, like using NSAIDs or hysterectomy with PSO, or both, all these combined together increase cardiovascular risk. And we should explore modalities to reduce the cardiovascular disease burden in women with endometriosis. So this is another meta-analysis which is published in ICOG 2025. It states that in this meta-analysis, they have included 7 cohort studies and they have followed up nearly 1.5 lakh women. And they found that the ischemic heart disease risk is highest in women with endometriosis, with around 35 increase in relative risk in women with endometriosis when compared to women without endometriosis. The cerebrovascular disease, arrhythmia, major adverse cardiac event risk is also increased. So these are the key significant findings where they found that cerebrovascular disease, major adverse cardiovascular events, arrhythmias, and ischemic heart disease risks is increased in women with endometriosis. And the common mechanisms why it happens is that because of hormonal imbalance, oxidative stress, immune dysregulation, and atherogenic lipid profile. So as we said before, the ischemic heart disease risk is around 35% higher relative risk, and it is due to chronic inflammation, endothelial dysfunction, dyslipidemia, and oxidative stress. So coming to stroke, cerebrovascular disease, the hazard ratio is 1.19. That is there is increased 20% relative risk in women with endometriosis, and this is also due to chronic inflammation, endothelial dysfunction. So there is increased risk of arrhythmias also in women with endometriosis. Why? Because chronic inflammation can lead to autonomic imbalance. It can also lead to structural myocardial changes and endothelial dysfunction. This can lead to arrhythmia in women with endometriosis. So another UK retrospective study also found that the heart failure risk is also increased. So major adverse cardiovascular events, which includes myocardial infarction, stroke, and cardiovascular death, all these three are increased in women with endometriosis with risk of around 15% increase in relative risk. Coming to atherosclerosis, usually atherosclerosis we see in elderly women. But in endometriosis, atherosclerosis occurs very young. And it is due to cellular and molecular changes which overlap between atherosclerosis and endometriosis. And the common pathway is inflammation, again oxidative stress, endothelial dysfunction, and cellular proliferation. Coming to hypertension, both is true. In women with endometriosis, the hypertension risk is increased. The relative risk is around 1.14%. And conversely, in women who have laparoscopically confirmed endometriosis, the risk of hypertension is around 1.29%. So why it happens? Because maybe due to increased use of NSAIDs in women with endometriosis for pain relief, it can lead to renal injury and in turn lead to hypertension. Early hysterectomy or BSO, which has been done in women with endometriosis, predisposes to hypertension. Also, recently it has been noted that endometriosis itself is an independent risk factor for developing hypertension disorders of pregnancy. Coming to dyslipidemia, again, endometriosis is associated with enhanced atherosclerotic changes, and unfavorable lipid profile is noted in women with endometriosis. There is 30% increased risk of hypercholesterolemia and 32% increased incidence of laparoscopic proven disease in a Japanese study. So this is the disease progression. So when coming to the treatment of endometriosis, in women with endometriosis, we usually advise hormonal treatment or surgery like hysterectomy, bilateral oophorectomy, or GnRH analogs or NSAIDs. All these treatment modalities itself can increase cardiovascular risk. So hysterectomy when done, hysterectomy with BSO when done in women younger than 50 years can increase risk of CAD and stroke. And hormonal treatments like combined oral contraceptives and progesterone, what it does is it causes increase in lipid profile and cardiovascular risk profile is increased. Also, sometimes it leads to weight gain, which also increases cardiovascular risk. So they might undergo ART. So in women undergoing ART with endometriosis, there is increased risk of IHD, ischemic heart disease, and venous thromboembolism when compared to women undergoing ART in general population. So psychological stress is a very important thing in women with endometriosis, and this stress itself can lead to cardiovascular risk. And usage of beta-adrenergic receptor blockers like propranolol can reduce this chronic stress and suppress angiogenesis. Also, tell me which is ART receptor blocker, can inhibit vascularization and it can reduce size in women with endometriosis. So estrogen has a dual role. It prevents cardiovascular risks but increases the endometriosis and promotes the growth for reducing both endometriosis and cardiovascular risks. Newer options are the use of multidisciplinary
Is there any connection problem? Dr. Tendel ma'am had left.
Hello?
No, Tendel is here. Tendel, you reshare your PPT. Your PPT is not seen.
Yes, ma'am. Okay.
Yeah. Start. Okay, you can go ahead. Make it full screen.
Yes, ma'am.
Go to slideshow, then you make the full screen.
Again. Yeah, the antiplatelet treatments for endometriosis, that is the low dose aspirin, what it does is it helps in reducing the lesion size, and it also decreases the fibrogenesis. So the ectopic endometrium size is also reduced, and it also helps in preventing the cardiovascular risk. Coming to the statins along with lipid lowering activity, it also has anti-inflammatory properties. So it helps in reducing the angiogenesis as well as the stromal cell version. So as obstetricians and gynecologists, what we should do in clinical practice? Whenever a woman with endometriosis comes to us, she should undergo blood pressure assessment, BMI calculation, diabetes screening, lipid profile, smoking assessment, and exercise counseling. She should be counseled that in future, she may have risk of cardiovascular diseases, and she should take steps to prevent it as well. So when a woman gets diagnosed with endometriosis, we should assess the traditional cardiovascular disease risk factors. BP, BMI, diabetes, lipid profile, smoking, physical activity should be assessed. Lifestyle should be optimized, and periodic follow-up is very much important. And early referral to physician or cardiologist is highly recommended if the patient comes under high risk. Thank you. Hello?
How are you, Vilma?
Yes. Ma'am, I'm sorry, my network is spotty, I think.
Thank you, Dr. Tendrol, for a very nice presentation, and especially it was an eye-opening for us. I didn't know much about this, so it is a very informative talk that you gave. I was just wondering, do you know about any studies that have shown that endometriosis patients, when they conceive, then they tend to have more PIH and more preeclampsia. So maybe that's also you could have included in this presentation.
Yes, ma'am.
That is because of the shallow placentation, no. That's the main reason they go in for preeclampsia. And again, you have the higher risk of abruption and placenta previa. So actually, in one of the suit conferences in Abu Dhabi, there was a paper which won an award of 1,000 euros for this particular topic on association of atherosclerosis or the lesions with the endometriosis.
Yeah.
So there are quite a good number of literature evidence starting from 2017. You have quoted recent 2023 and 25 articles are also there to show that there is a long-term association between the two.
So especially these elderly women who conceive, who have got endometriosis and who conceive, maybe they may be having some heart problems also. So it would be a good idea to screen these patients regularly.
Yes, ma'am.
Yes.
Nice.
Thank you, ma'am. Thank you for giving me this opportunity, ma'am.
The next talk
by Professor Dr. Mitra, sir.
Yeah. So the next talk is by Dr. Pradeep Kumar Mitra, and it is on endo creating awareness amongst adolescents. So Dr. Mitra is the founder and Secretary General Endometriosis Society India, past President Bengal of Gynae Society, working on endometriosis and adenomyosis for past 23 years. He has been organizing Secretary ICE in 2025. Has got lots of publications and has been international faculty in various prestigious conferences, and has been past faculty in University of Illinois, Chicago, past faculty in Yoshida Hospital, Japan, and visiting experimental endometriosis research fellow in Canada, and principal investigator in NHS Southern Health Foundation, UK. So we are so blessed to have such a prestigious person with us. So welcome, Dr. Mitra, for your talk.
Thank you very much for the. Can you hear me?
We can hear you. Yeah, we can hear you.
Am I audible?
Yes, you are audible.
Okay, thank you.
You are audible,
Dr.
Dr.
Thank you for
Mitra.
the kind words. Let me share the slides.
Sure.
Okay. See my slides? Can you see?
No, we can't see your
Can you
slides.
see my slides?
You have to share the screen. We can't see
Hello?
the slides. Please share the screen.
I've shared it.
No,
Just
we
wait,
can't.
sir. It's coming, sir.
I
Just
shared
wait.
it.
Yeah, it's coming.
Yeah, now it's there.
Is it okay? It's okay? Okay. Thank you for the kind words.
Perfect.
In fact, probably this is the most neglected topic I have speaking, and I'd be talking about the ground reality. Now, I'm not going to define what is endometriosis. But we all know its causative factor is unknown yet, and unlike cancer, there is no biomarker to test it in the form of a mass screening program. Now, in a study, there are 253 million adolescents in rural India, and only 20%. And what about the adolescent endometriosis? 60 to 70%. So, in our hand, we have suspicion followed by early detection. That should be our goal. Now, 17 years back, our then teacher, late Professor B.N. Chakraborty, used to talk about the vital role of awareness cum screening of very adolescents, and he used to teach us three mantras, that is prediction and prevention, catch them early and strike at root. And he used to tell us, well, endometriosis would be one clinical diagnosis. Unfortunately, the advocacy is most underrated, and we are lagging behind the spreading of awareness in the committee. Most of the time, we are busy in teaching ourselves in the various conferences. We hardly teach the general practitioners and general population, and that is our lacunae. Now, just a reminiscence. Way back in 2012, when I was grossly engaged in public awareness program, most of the girls and teachers had never heard of a disease in the school called endometriosis, but they were familiar with the term cyst and the way the polycystic ovarian disease. The scenario remained the same even today, that is 2026. Ideal approach of spreading endo awareness, which is now one global epidemic. There are 7 areas. The intention should be to cover the entire adolescent population of India. The target population should be peri-adolescents, teachers, and guardians, and it should be one round-the-year awareness program in all schools, from the class 6 to class 12 and colleges as well. And it should be a population-concentrated program, particularly in remote rural areas to suburbs, and it should be one dedicated program and not sporadic only in the cities. Involvement of NGOs, general practitioners, co-works, paramedics, and youths should always be there to make it successful. And lastly, innovation in the variety to share the information is very much important. I'll come to that later. TV program. Yes, we used to do a lot of TV programs during that time, and then this is one of the finest lifetime memory of mine. For one side, you can see late Professor B.N. Chakraborty, the then legend, and the other side, the founder, Secretary General of Endometriosis Society, Mr. P. Das Mohapatra, and this was a lifetime live TV telecast, which is telecasted all over India many times on awareness of adolescents. This is awareness of the parents, which I usually prefer all the time. And this is another picture around COVID area, pre-COVID or post-COVID area. You can see the masks are there. And this is also a picture of the village where this program is going on. And all age groups should be involved in these types of programs, which have been shown over here. Unlike this is one sophisticated program in a very high-class school there at Varanasi, and you see Dr. Umrada Khanna is conducting the program, and so on. But I talked about variety. all of you are aware or seen political rallies or rallies on religious programs. But have you ever seen these rural women? They're walking, holding the banners and posters, showing various information when they met. And the last time we started this, and this happened in rural areas, and but there. Now, we also used to take our and you can see the boys and girls, roses, and people passing by. Used to ask a lot of questions to them. But why? I felt this is much more important. Before that, I want to show you one small video. I'm not showing the full one because it will take time. See the picture. 15-year-old girl had 7 consultations or more in different hospitals, had various surgeries like appendectomy and many others, and she was never thought of as a case of endometriosis. And ultimately, she came to me, and I found that vaginal involvement and its surgery. Of them are rising progressively. Secondly, and the poor girl is a sufferer, compensated very late. The onset detection interval is found is around 8 to 12 years, particularly in rural area. Progress of the disease is around 10% as per geographical variation of India, and not only affects the urban population but also probably much more in rural sector. I found that there are 2 failures from our end. Number one, we failed to study the problem in a systematic manner, and we advised sporadically without any follow-up. So my second innings had started with the intention, number one, to register all the adolescents to support or suspect provisionally diagnose the disease by non-invasive approaches, to avoid the usual diagnostic delay of 8 to 10 years in endometriosis, and thereafter to promote a lifetime plan to avoid various difficult and complicated surgical procedures, to promote conception, and to side by side we attempted to detect asymptomatic endoadrenal complex. There have been 3 approaches. The number one, the most important, the modified school visit program for awareness screening, and the targeted beneficiaries included pre-adolescent and adolescent girls, plus their guardians, and mostly in rural population. And our dedicated team included the dedicated NGOs, which is most important, then school authorities and teachers. Third is endo warriors. I'll come to that. Who are endo warriors? And last but not least is one dedicated gynecologist. And we've had in our hand endometriosis screening form, the hard copy. This is the first page of the hard copy containing the questionnaires, and this is the second page which were prepared during that time. He started in the year 2024, and the link contained one audiovisual lecture on endo and awareness, which had been monitored by the class teachers and endo warriors. And one, our society members was there always in online to give advice as per need. This is the approach, and here, as I've already said, the role of social welfare organization is very important to get into touch of the schools and the population. There are several components. The number one, at the school, first order to the audience, distribution of that endo survey form had been done, and then it is followed by one little basic lecture for 40 minutes or so. This is to be followed by one question answer session, for which usually lasts for 1 hour. Then all the forms had been collected from the students, and another date had been fixed for checkup, and advice. This is one such school where the same two procedures are done on 2 days, and 553 girls are screened in 2 sessions. And as you can see, in the next day, uh, another day was fixed for advice and all. We used to get a lot of support from the border security force, and we could do programs anywhere or any part of India with their support. Incidentally, we from our society, Bangladesh Society, Bangladesh Endometriosis Society had invited us to do some program over there, particularly on awareness, and we did quite a few programs there in Bangladesh. I can see these programs, and this is our rural school in Bangladesh, local team there in Bangladesh, and my own team in Bangladesh. Unfortunately, Bangladesh society started much later than Innovative Society India, but they have gone beyond, miles beyond us in this particular program of India awareness screening for pediatrics in schools and colleges. I'm very much happy to see that they learn from us, and they're running much faster than us. And now I'd like to show a brief of our pilot project, which we did in 2023 and also going on. You can see the forms over there, the field of digital endo screening forms, which are waiting to be screened. Consent of the guardian was mandatory to participate in the survey. Nearly 4,300 participants were there, and screening had been done. And symptom-based rating, the 5 ratings have been done. The number 1 is the normal or control, grade 1. That means no menstrual complaint or mild pain. Then grade 2 included progressive dysmenorrhea plus history of neonatal uterine bleeding with or without history of rather family history of endometriosis. Grade 3 included CPP or NMPP. Grade 4 included progressive dysmenorrhea or CPP causing incapacitation of normal activities, particularly absentees in the school. And grade 5, all these things with bowel or urological symptoms. Now, initially, there are quite a few dropouts, but in the later stage, the dropout rate was not much. Almost everybody participated. This is one tabulation as pre-treatment tabulation, where you can see all the 5 grades and their corresponding numbers have been shown in this slide. Now, the management which started during that time was that for grade 2, initially we used to give analgesics and NSAIDs and watch for 3 cycles. 10% usually become asymptomatic, but 90% the symptom persisted, to whom, along with those belong to grade 3, 4, and 5, we used to give trial drug therapy in the form of continuous low-dose OCP, which had been advocated for 3 to 6 months after excluding the basic contraindications of OCP, and they were observed for the outcome. Now, the reports or results post-treatment trial are partial to complete relief within 3 months, and they went into a state of, almost many of them went into a state of and only 30% didn't get that much relief. So a provisional 2, 3, and 4 cases who became asymptomatic in 3 months, and they were advocated to continue the same regime for another 3 months, and they were regularly followed up. But in the rest, 30% to whom in whom that much of relief is not observed. Ultrasonography was not ultrasonography, not much abnormality could be detected. In few cases, eoma, adenomyosis at the end had been detected, but all of them were put on diagnosis or a TMPA, and they were referred to tertiary center for review, HR, EVC, or laparoscopy, or whatever they think best. But all the girls are kept under strong supervision. This is the statistically significant results from our end, and this is other statistical data. I'm not detailing them. And in literature, I found only very few literature in this particular area. And this is another endocrine study, a French study, but that was also on a diagnosed case and the age of between 18 to 45. So that's not much of any importance to us. So I felt that modified endo awareness screening for pediadolescents for the target population appeared to be most effective, but the class teacher is taught to continue a regular and periodic lessons, particularly those who are coming in the new class in the next year. Good coordination between NGO and class teacher and guiding specialist is very important. And with the digital distribution or into survey form and online checking feedback, this is becoming much more helpful and efficacious. So a good coordination, as I said, between NGO, school teachers, and the gynecologist is the key to success of this particular day. I think they are the future of this particular program to conduct in the form of mass awareness into screening. They were actually volunteers from adolescent endo sufferers, and their friends. They used to take the charge of this particular job, and they received appreciation award from us in international conference of endometriosis from the year 2023 onwards for best performance. And here you can see these NGO leaders and endo awards are there who received prizes and appreciation awards. The second approach is the role of GPs. India versus North America. In North America and UK, the GPs are knowledgeable enough to diagnose and treat adolescent endometriosis the earliest, unlike us in India and in developing countries where the GPs have very little knowledge or rather nil knowledge on this particular disease, and they send the patient to the gynecologist very late, who are also not that conversant on this particular disease, understood from my long association with this particular disease, and uh, the actual diagnosis is being made very late. So second approach has got two components. One is end awareness training to general practitioners and paramedics, and then waiting room screening. Here you can see how this paramedics and general practitioner has been trained or given knowledge of endometriosis, and this is waiting room survey with the posters. Here, the posters containing the information on endo have been displayed, and the chambers of general practitioners and a modified simple endo survey form is being distributed from the counter or from the reception to all the girls, and so that the general practitioner can at a glance during consultation can see the highlighted areas from that into survey form and send the patient quickly to the gynecologist without making any delay. So progressive dysmenorrhea and CPP were found in over 40% of the cases in that study. The third approach is most difficult, and that is to get the help of imaging specialists and laparoscopic surgeons to opine on pelvis on non-gynecological procedures when being done. So general laparoscopic surgeons are rather reluctant, but on a request they did it in quite a few cases, and just running through these areas, and in quite a number of cases this type of findings was there. And so role of somnologist was also important. They were much more compliant than my surgeon colleagues, and looking to the pelvis while doing USG for other conditions like whole abdomen or so in the upper abdomen. So these are the pictures of imaging specialists. So outcome of this targeted radiology project is very important to me, so that we could make a provisional diagnosis in about 70% cases compared to 25, and we could initiate the treatment, resulting in reduction of sufferings and onset detection interval, and which is being most important to fight against endo. And involvement of GPs, as I said, and endo warriors are very crucial in this particular project. So after that, I thought that our job is not yet over. In the part 2 part of this job, in the tertiary care center, we used to look into the non-gynecological areas of this particular pain, apart from gynecological examination, particularly GI tract, urinary tract, musculoskeletal syndromes, viscera, neurological problems, psychiatric comorbidity, etc. There, we used to look after all these areas, and a multidisciplinary diagnostic approach was required, which have been highlighted many times over here by many other speakers, and consultation with gastroenterologist, urologist, and psychiatrist, along with uh, doing one high resolution USG by specially trained imaging specialist on endometriosis, and MRI may or may not be needed, and sometimes we used to do mini laparoscopy, and that is controversial. The step I am showing, this stepwise USG, the 4 steps, which are very important, and I'm just skipping all these few slides. These are few mini laparoscopy slides. There's some associated complaints which have been shown, and these are the. This is one old slide, very old slide, where normal-looking endometrium and peritoneum, normal-looking, absolutely normal-looking peritoneum, showing endometrial implants in scanning, ultrasound, scanning, electromicroscopic view. It is a slide of 2005. Now, the final management needs a thorough counseling followed by medical and or surgical management, mostly medical management, and there is no single best treatment for endometriosis, particularly in adolescents. But one important area, primary preventive advices can always be provided along with awareness and or screening, particularly on lifestyle modification in this 7 or 6 areas. Load of diet is very important, and these all delicious diets are most dangerous for endometriosis. Then laptop on the lap along with sedentary habits, junk food, and no exercise is a very combined conditions where advice should be given according to that to go for exercise and avoid sedentary habits. Then addiction to cell phone is another gray area to some extent. The electromagnetic waves that is being radiated results in reactive oxygen species, which has got effects on ovaries and testes for the boys, and they have got effects on facial wrinkles, premature aging, and also effect on brain as well. And not detailing it, there are many side effects of cell phone which should be made aware to all the adolescent girls. Is that of this cell phone, that AI and mobile phone protocol, symptom tracking system, and endo support system could be done. And lastly, smoking and alcohol. Well, smoking, it is a bit controversial, but alcohol significantly aggravates the symptoms or the status of endometriosis. So, the home remedies, particularly dietary change, low gluten diet, sugar statement those to be avoided, herbal supplements, particularly turmeric. Turmeric can cure endometriosis, light exercise, etc., should always be done. So, in conclusion, I will say that this particular job is apparently a thankless job. Why? Because there is no incentive or no remuneration. There is no academic partner available for that. Many renowned NGOs, they're not interested, and non-medical youths, why they spend their valuable time for that? And public awareness committee, well, that is there everywhere. There is a big name, white media coverage in the city, but nothing there in the rural areas. And lastly, young gynecologists, they think always better to spend time for endoscopy, ART, and other things. Final line, incidence of endometriosis is increasing, but underreported. So widespread awareness, specifically in rural population with earliest suspicion, followed by detection in initiation treatment, might result in subsequent extensive surgery and recurrence, and optimize the quality of life from adolescence onwards. I express my heartfelt gratitude to general physicians, paramedics, and NGOs, class teachers, and endo warriors. And thank you very much for patient hearing. Thank you.
Nico. எங்க தம்பி அவனை கூப்பிடு, வீட்டுல போய் காரை வச்சுட்டு போக சொல்லு.
Thank you, sir, for your valuable presentation.
பா இங்க பாரு, நீ வீட்டுல போய் காரை வச்சுட்டு போ. அந்த சாமான் எல்லாம் இங்க வை, எனக்கு 2 ஆபரேஷன் இருக்கு.
தேங்க்யூ.
Asha ma'am and sir, Shaiju sir, your opinion? I think share.
Thank you very much for the excellent talk. And I think, yes, awareness amongst adolescents is very, very important. And using these tools and sensitizing the GPs and putting them in the OPTs and all, displaying them in the OPTs will really increase the awareness amongst the youngsters. And I think it's a very good idea. So thank you very much, Dr. Mitra, for such an excellent talk. I think Shaijas is not there.
Thank you, Asha, for your nicely chairing the session. I think next we have the MCQ questions, which Harshini will be conducting.
Ramni, can I leave now? Because I've
Yes,
got
yes,
some...
yes, you can leave. Thank you so much.
Thank you, everyone. Thank you, Dr. Pradeep, Dr. Harshini. Thank you, everyone.
Thank you so much, ma'am. Thank you. Thanks a lot. And Pallavi, can we have the MCQs? So, which emerging biomarker has shown promise for non-invasive diagnosis of endometriosis? A, CA-125 alone. B, serum progesterone. C, circulating microRNAs. D, AFP. The answer is C, circulating microRNAs. Can we move on to the next question? Which of the following is considered one of the most promising future therapeutic targets in endometriosis? A, GnRH stimulation. B, neuroangiogenesis inhibition. C, increased estrogen production. D, oxytocin receptor activation. Sherry Nash. Last 5 seconds. Neuroangiogenesis inhibition. Artificial intelligence in endometriosis is currently being explored primarily for A, determining blood group. B, automated ultrasound, MRI interpretation and disease prediction. C, replacing laparoscopy. D, hormonal therapy selection based only on age. Last 5 seconds. So the answer is B, automated ultrasound, MRI interpretation and disease prediction. Which technology is expected to improve individualized treatment in endometriosis? A, universal GnRH agonist therapy. B, precision medicine using molecular profiling. C, routine hysterectomy for all patients. D, long-term antibiotics. Last 5 seconds. B, precision medicine using molecular profiling. Which statement regarding future research in endometriosis is true? A. Surgery is expected to remain the only treatment. B. Biomarkers have already replaced laparoscopy. C. Personalized therapy based on genomics and immune profiling is an important research direction. D. Endometriosis is no longer considered an inflammatory disease. C. Personalized therapy based on genomics and immune profiling is an important research direction. According to the current guidelines, the first line management for pain in women not seeking immediate pregnancy is A. Immediate surgery, B. Medical therapy, C. IVF, D. Hysterectomy. Last 5 seconds. The answer is B. Medical therapy, which is not considered an advantage of medical management over surgery. Avoid surgical complications. B. Can reduce recurrence of pain. C. Improve symptoms without removing ovaries. D. Permanently cures endometriosis in all women. Last 5 seconds. The answer is D. Permanently cures endometriosis in all women. The major reason for increasing preference towards long-term hormonal therapy is A. Endometriosis is a chronic disease with recurrence. B. Surgery is always contraindicated. C. Hormones improve fertility in every patient. D. Surgery has no role. Last 5 seconds. Answer is A. Endometriosis is a chronic disease with recurrence. Which hormonal therapy has the strongest evidence for long-term suppression after surgery? A. Combined OCP. B. Levonorgestrel resistance. C. Dynages. D. Both B and C. Answer is both B and C. Which statement best reflects the current treatment paradigm for endometriosis? A. Operate first in all women. B. Medical therapy should be individualized with surgery reserved for selected indication. C. GnRH agonist should be lifelong. D. Every ovarian endometrioma should be excised before IVF. Last 5 seconds. Answer is B. Medical therapy should be individualized with surgery reserved for selected indications. Next question. 11th, which of the following is considered the most important pathophysiological mechanism linking endometriosis with increased cardiovascular disease? A. Hypercoagulability due to factor V Leiden mutation. B. Chronic system inflammation leading to endothelial dysfunction. C. Increased progesterone sensitivity causing vasospasm. D. Elevated erythropoietin levels causing vascular remodeling. Last 5 seconds. The answer is B. Chronic systemic inflammation leading to endothelial dysfunction. Which biomarker is most closely associated with endothelial dysfunction observed in women with endometriosis? A. Elevated troponin I. B. Reduced reactive hyperemia index. C. Elevated NT-proBNP. D. Increased D-dimer. Last 5 seconds. The answer is B, reduced reactive hyperemic index. Next question. A 34-year-old woman with laparoscopically confirmed endometriosis presents for annual follow-up. She has no conventional cardiovascular risk factors. Based on the current evidence, which counseling statement is most appropriate? A, endometriosis has no effect on long-term cardiovascular health. B, cardiovascular screening is only necessary after menopause. C, endometriosis is associated with an increased risk of cardiovascular disease and modifiable risk factors should be assessed periodically. D, cardiovascular risk is increased only in women who undergo hysterectomy. C, endometriosis is associated with an increased risk of cardiovascular disease. Modifiable risk factors should be assessed periodically. According to the latest meta-analysis, women with endometriosis have the greatest increase in risk for which cardiovascular outcome? A, heart failure, B, ischemic heart disease, C, cardiac death, D, dilated cardiomyopathy. Yeah, last 5 seconds. B, ischemic heart disease. A 30-year-old woman with severe endometriosis asked, should I be worried about my heart? Which is the best response? A, no cardiovascular disease is unrelated to endometriosis. Yes, should be immediately statins. C, women with endometriosis have a modestly increased cardiovascular disease. Maintaining a healthy lifestyle and controlling traditional risk factors is recommended. D, cardiac investigation should be routinely performed every year in all women with endometriosis. Last 5 seconds. The answer is C. Women with endometriosis have a modestly increased cardiovascular risk. Maintaining a healthy lifestyle and controlling traditional risk factors is recommended. Last 5 questions. Should we go for clinical screening of adolescents while doing awareness? A, ideal. B, yes. C, no. D, don't know. Last 5 seconds. A, ideal. Next question. Who can regularly give awareness to schoolgirls? Mother, class teacher, C, doctor. I think Pradeep sir has given all easy questions. Every time his questions are very easy. Last 5 seconds. B, class teacher. Progressive dysmenorrhea, bar NMPP in girls with school absentee should be kept under watch. Yes or no? Last 5 seconds. Yes. Next question. Mother, parents should be made aware of this disease. A, yes, B, no, not needed. Last 5 seconds. A, yes. So the last question for today. Primary caregivers, general practitioners should know about this disease and take part in screening program. A, definitely. B, not necessarily. Last 5 seconds. A, definitely. We've come to the end of quiz session. Can we have the winners? Dr. Vandana Gupta. The second one is Dr. Supriya, and third is N. Aisha Khatun. Congratulations. Thank you so much for today's evening, and the evening was very informative and elaborative. Thank you for each and everyone who's been participating in this webinar. Thank you so much. I thank Ramni ma'am, the chairperson.